we're back for part 2, chapter 41, management and resuscitation of the critical patient. Let's go ahead and get started. So we're going to talk about some causes of shock. Remember, first video we talked about physiology, pathophysiology of shock and what happens at all the way down, cellular level. So now we're going to kind of just really talk about some basics of shock, not just the working of it, but how we might see it, the different types of it. So causes of shock, we see, that's what we're going to talk about, can result from a whole variety of conditions. So, what they do is they lead up to some critical health issues. So damage occurs due to that insufficient perfusion of organs and tissues, which can lead to cellular injury and then organ dysfunction. So if shock's not quickly, halted or corrected, then that patient faces a high risk of death. So within these patients, obviously we need to maintain a high index of suspicion when we're talking about patients that might be in shock. So paramedics, as a paramedic, we need to maintain a high index of suspicion for shock in multiple scenarios, including massive external or internal bleeding. So, that significant blood loss can lead to hypovolemic shock. Multiple severe fractures or multi-system trauma as well can result in blood loss and subsequent shock. And then abdominal or chest injury, so that can lead to hemorrhage or organ damage. Spinal injury, cause some neurogenic shock due to disruption of the autonomic control. Of course, severe infection, so sepsis can lead to septic shock. A massive MI, so a heart attack can decrease that cardiac output and the perfusion. And then anaphylaxis as well, so severe allergic reactions can lead to distributive shock. So there's lots and lots of things going on here within shock. So we've talked about it a little bit on the last video, but we see there's really 3 pieces to the puzzle here when we talk about the circulatory system. You remember we have the pump, we have the pipes, we have the fluid. So when we start talking about kind of 3 basic causes, one of them would be pump failure, so the heart is unable to pump effectively, and then that in turn leads to decreased cardiac output. And then we go to the fluid, so low fluid volume, insufficient blood volume due to hemorrhage or dehydration, and that can result in hypovolemic shock. And then we get into the vessels or the pipes, so vascular issues that prevent proper blood flow, often seen in conditions like sepsis or anaphylaxis. And there's certain patients that are obviously at risk for this. High-risk patients, when we start talking about that, is a patient with trauma or bleeding, so that significant blood loss increases the risk of shock. Patients with massive MIs, so heart attacks can severely impair the heart function, leading to cardiogenic shock. Pregnant women, physiological changes can increase the risk of shock during pregnancy or complications. And then patients with septic shock, so that with sepsis, that infection can lead to widespread dilation, vasodilation, and fluid loss, causing shock. And then, of course, older adults as well. So, often experience already a decreased cardiac output and reserves. So then it's compounded conditions, with the trauma and all of that affect vasoconstriction. So let's talk about the progression of shock. So we got a couple phases. We got 2 successive phases. So shock occurs in just 2 main phases, compensated and decompensated. And these phases are also referred to as, you might see it as the 4 grades of hemorrhage or the 4 classes of shock. So classes 1 and 2 are a compensated shock. And when we say compensated, remember back to the prior video with what the body was doing, able to compensate for it, increase the heart rate, and able to hold on to fluid and all of those things. So the body's able to maintain adequate perfusion, and then that blood pressure is also able to be maintained through compensatory mechanisms. That's where the name compensated shock comes in. And then classes 3 and 4 are decompensated shock. So the body's compensatory mechanisms, they start to fail, leading to inadequate perfusion. And then, of course, you have an increased risk of organ dysfunction. So once again, we talked about classified into compensated, decompensated phases, which correspond to the 4 classes of shock. So 1 and 2 represent compensated, where the body can still maintain adequate function. 3 and 4 decompensated, where significant failure of compensatory mechanism starts occurring. So recognizing shock, that's going to be really important. Early recognition is going to be one of the keys. So it's crucial to recognize the signs and symptoms of shock early to initiate immediate treatment and prevent further damage. Now there can be some subtle signs, so be aware of those that may indicate that the body is compensating for shock. So some really simple things would be like the blood pressure is pretty normal, but they are a little tachycardic, so that the heart is compensating. And that doesn't necessarily mean every patient that you run on or every patient in a car crash that's tachycardic and normotensive is experiencing shock, but that's one of those compensatory mechanisms that we talked about. So don't rely on just that single indicator, on any one sign or symptom to determine the phase of shock. A comprehensive assessment is going to be necessary for this. So we want to provide a rapid assessment of the patient's condition, and then arrange for immediate transportation to a medical facility. Now, altered mental status, that's going to be a late indicator of shock and may signify advanced decompensation. So let's talk about compensated shock. Compensated shock, as we mentioned, the earliest stage of shock where the body can still compensate for blood loss. So that level of responsiveness is the best indicator of tissue perfusion during this stage. There's some physiological responses that go on. So we talked about those chemical mediators. So the release of chemical mediators, they help maintain normal or elevated arterial blood pressure. We see some respiratory changes. So the rate and depth of respirations increase. That's to enhance the oxygenation process. And then we see some blood pressure maintenance. So blood pressure remains stable despite that blood loss. Now, in hemorrhagic shock, blood loss is typically around 15 to 30% at this point. So when we're talking about that compensated shock, somewhere between 15 to 30% is what we're talking about. So the pulse pressure starts to narrow as compensation occurs, and then they may exhibit like a positive result if you were to do an orthostatic tilt test, so indicating changes in blood volume or the pressure as well. Now, decompensated. So when we talk about decompensation, we expect there's probably a lot more blood volume loss. So in decompensated shock, blood volume drops more than 30%, and we start to see that failure of those compensatory mechanisms. So they start to fail, which leads to significant physiological changes. So some of those signs and symptoms that we were seeing before, they become much more pronounced and obvious. So cardiac output falls dramatically as the heart struggles to maintain circulation. And then we see that blood shunting, so that blood's redirected to those vital organs such as the brain, the heart, the kidneys, and then even cellular. So those cells within non-perfused tissues become hypoxic, and that leads to anaerobic metabolism and then potential tissue damage. So once we get a drop in blood pressure, if we detect that, then shock is probably well developed. So we need to be able to, we want to really stay ahead of this and get them to the right place at the right time, as well as some interventions that we'll talk about. So with children and infants, this is particularly true for children and infants who maintain blood pressure until experiencing a loss of somewhere between 35 to 45% of blood volume. So we want to make sure that we consider decompensated shock an emergency. We begin transport within less than 10 minutes. We want to make sure that we're providing resuscitation efforts en route to our medical facility. So we said that, that decompensated shock characterized by a significant drop in blood volume, so more than 30%, and then those failing compensatory mechanisms. And that, of course, leads to those obvious signs and symptoms. And then we get into irreversible, so think of just about that term, irreversible shock. No matter what we do, it's not going to get reversed. So irreversible shock represents that point at which shock has progressed to a terminal stage. And, we see some characteristics of that, which rapid deterioration. There's this rapid and irreversible decline in the cardiovascular status. Significant decreases in cardiac output, blood pressure, tissue perfusion occur. We start to see the damage to those organs. That becomes irreversible and cannot be repaired. So really aggressive treatment usually does not result in recovery, indicating a critical and often fatal condition when we're talking about this irreversible or terminal shock. Now, patient assessment. Nothing new here. size at the scene for our hazards, follow standard precautions. If this is a trauma patient, there's probably a whole lot of blood everywhere, so we want to make sure that we're suited up, ready. Determine the number of patients, need for additional resources, and then assess the MOI or the nature of illness. Now, our primary survey, we want to evaluate how the patient appears. So really, at this point, we're just kind of giving it just this look test, indicating a need for some fast tracking based on mechanism of injury or even just the nature of illness, because it's all shock patients are not just trauma patients. We want to do our AVPU, assessment. And then we want to interact within the patient. So, we want to introduce ourselves to the patient and ask some questions, their name, their location, their day of the week, or not their day of the week, but the day of the week, so we can kind of start to determine where things are for them. Now, with our airway and breathing assessment, we have this kind of sequence of assessments. So if cardiac arrest is suspected, we know by AHA standards, we flip that ABC into CABDE. So circulation goes first, and then airway breathing, then disability and exposure. Now with a life-threatening bleeding, if we have some life-threatening bleeding, we have started, there's kind of a new little thing that got added in, and it's an X. So you see X, A, B, C, D, E, and that X is exsanguination. So things from the inside are all coming out to the outside. So we want to control that bleeding, then go on to our ABCs. So really, it's nothing new. It's just that they've placed an X in front because we were always taking care of life threats, apparent life threats. So that might have been gross bleeding or whatever that we're talking about. So otherwise, we just want to assess our ABCs, manage our immediate threats. So patient's airway, breathing, do a chest exam. So, in these trauma patients, we'd look for Flow segments. So you should remember that's a section of the chest wall that moves independently from itself, basically. So, or impaled objects. So, it might be obstructing the airway or causing injury. Look for any holes in the chest that need to be sealed. And then we want to assess the adequacy of their ventilations to ensure proper oxygenation, as well as carbon dioxide removal. Then circulation assessment. So patients with a pulse, determine if it's adequate to sustain life, and then perform a rapid exam to check for any external blood loss that can be controlled. So with those conscious patients, we'll assess the pulse at the radius, so at the wrist. Unconscious patients will check the carotid, pulse, and the neck for circulation status. And we want to check for pulse quality, so we want to evaluate the quality of the pulse, and then is the radial pulse weak and thready, is it irregular, just these assessment skills that hopefully we already have in our toolbox there. So hypotensive patients, immediate transport. So if that patient is hypotensive, we want to provide immediate transport to the emergency department. We want to note their skin, so you'll see in your text the CTC, so the color, the temp, the condition. So the color, we're looking for any unusual discoloration. Might be pale or flushed or cyanotic. Temperature, we want to see if it feels less warm, so is it cool or cold. Condition, we want to assess the skin's overall condition, so is it moist, dry, clammy. And then body heat retention. So we want to cover the patient to help retain that body heat, especially if they show signs of hypothermia or shock as well. And then transport decision. These kind of patients that we're talking about, probably if we're thinking that they have shock, we should know that they need to be prioritized, based on their condition. So if they're experiencing shock due to a medical issue, then, we need to get moving. We need to fast track that patient to an assessment based on the body system involved. Now, if it's trauma, we want to use that mechanism of injury to guide our assessment and our subsequent actions. So timing, as we're talking about this history taking, history taking can be conducted en route. So timing is going to be really important for this because we don't want to mess around on scene, especially with things that we can do en route, things like getting our history from the patient. Now, we want to make sure, speaking about that on-scene care, we want to keep our on-scene care limited to just those essential items that must be completed before moving our patient. So, really, unless that patient is pinned and delay in extrication suspected, we want to not delay establishing the IV and IO route, the IO access on scene. We'd rather do that en route to the ED. So some secondary assessments, shocks categorized by hypovolemic or maybe hemorrhagic until proven otherwise. So if a patient's in shock, we're saying that it's hypovolemic or hemorrhagic until it's proven otherwise. So a drop in systolic pressure or altered mental status, that indicates that the body can no longer compensate for that shock. We already talked about that, but we want to monitor other indicators of shock if we're able to. So end-tidal CO2, that can kind of provide some insight into your patient's respiratory status. Maybe you're able to check their lactate levels. So elevated lactate levels indicate metabolic distress and may serve as an early indicator of severe sepsis. So those monitors can really help facilitate rapid assessment. And then you want to utilize sepsis alert programs for early recognition and management of sepsis. And then reassessment. So, revisit your primary assessment, including your vital signs, your chief complaint, anything that you've done for them. You want to assess what interventions are needed for your patient, focusing really on the cardiovascular system. Treat for shock early and aggressively. And then those patients that are in decompensated shock, they're going to require rapid interventions to stabilize their condition. Now, emergency medical care of a patient with suspected shock. So when we talk about this, when we talk about, these patients with suspected shock, then airway and ventilatory support is going to be really important. So that should take top priority when we're treating shock. So we want to make sure that we're maintaining an open airway and suctioning the airway to clear any obstructions they might have. We're administering high flow O2, assisting ventilations if needed, controlling hemorrhage, all of those things. Nothing really new. Assessment for internal hemorrhage for a patient that we think might have an internal bleed. We want to look for those signs of internal bleeding. So consider the potential for blood loss in an area where the hemorrhage may have occurred, and then take into account the mechanism of injury and maintain that high index of suspicion for occult injuries as well. Now, IV therapy in treating shock. So IV therapy can be beneficial in supplementing initial treatments for shock. We want to perform that IV therapy en route, as I mentioned, to the ED. It'd be best to get two 16 to 18 gauge catheters if possible. And then we want to administer IV volume expanders to replace that lost blood. So, we're going to probably use isotonic crystalloids for fluid resuscitation and maintain perfusion. So we want to aim to maintain perfusion without exacerbating the internal or uncontrollable external bleeding. So in the absence of TBI or a traumatic brain injury, we want to administer around a 250 ml bolus and then reevaluate the blood pressure after each bolus with a maximum of 4 of those in a pre-hospital setting prior to obtaining online consultation. So we want to note that the radial pulses correlate with a systolic blood pressure of around 80 to 90. However, that is not always true. So, sometimes people run with this kind of hard and fast rule of that, and it's not true. Now, talking about this blood pressure and using fluid, there's something called permissive hypotension. So I've put a link on there if you want to copy and paste it or just type it in. But it's a white paper. I'm just going to read directly through it. So that permissive hypotension is just using enough fluid to basically get our blood pressure somewhere between 80 and 90, and we talk about that in a second. But I want to read from this paper, which says introducing excessive fluids. And I say that because in the past we've ran way too many fluids. It wasn't uncommon for a patient to get a liter or 2 that was a trauma patient. It wasn't uncommon for someone to try to get their blood pressure back up to, quote, normal. And it's very, very bad for people. Now we know this. So introducing excessive fluids in the trauma setting can cause abrupt cardiac preload and output increase. So a MAP increase reduces peripheral vasoconstriction and produces further blood loss. Excessive fluid Repletion may also disrupt the body's natural coagulation response, potentially leading to dilutional coagulopathy. Managing the overhydration induced coagulopathy requires blood product supplementation to restore hemostatic balance. So some studies talk about between 80, this particular white paper I believe said 80 to 90, which is what most people do, keep it under 90. But there's a number of reasons, because the heart's having to work harder. We're also blowing out those clots that the body has worked really hard at creating, as well as we're filling up the entire vascular system with fluid that doesn't carry oxygen. So essentially, I like to just, it's not my phrase, I just kind of coined it, but we're watering down the Kool-Aid basically. So if you've ever seen those patients that a whole bunch of fluid was pushed on, when fluid comes out of them in injury sites, it's just barely pink, because they've had so much fluid ran into them. However, as always, follow your local protocols. So, talking about those emergency interventions for shock, we're still talking about patient care, emergency medical care of a patient with suspected shock. So patients with maybe a tension pneumo, so if they have signs of that present, we want to perform a needle decompression, and then maybe a suspected cardiac tamponade. We need to recognize the need for rapid transport to the emergency department for a pericardial centesis or even just a rapid ultrasound. We want to always follow our ALS protocols regarding these interventions. Now, non-pharmacologic interventions. So I go into a little extra here, and once again, as always, you'll follow your local protocols. But when you talk about positioning the patient, you see proper positioning of the patient, and if you're like me, you want to know what quote proper means. Well, position your patient appropriately to optimize circulation and breathing. So you have a supine patient, so this is often the safest initial position for most shock patients. So it promotes that circulation of vital organs without compromising airway or breathing. Then we have the old traditional Trendelenburg. So this was historically recommended, but it's now rarely used. So studies suggest it offers little benefit and may impair respiratory function as well. And then there's a modified Trendelenburg. So that's raising the legs approximately 6 to 12 inches, may be considered in hypovolemic shock. If there's no contraindications like a spinal injury or fractures, it helps venous return to the heart temporarily. So I kind of compiled a little bit, just a list of shock types and then their positioning. So hypovolemic shock, so we're talking about hemorrhage or dehydration. That position would be supine with maybe the legs elevated if tolerated. What that does, the thought behind that, it maximizes blood flow to vital organs without exacerbating fluid loss. So cardiogenic shock, so heart failure, maybe an MI. So that's going to be that semi-Fowler's, or sitting upright with the legs down if the patient is dyspneic. So that reduces the workload on the heart, and it also alleviates or helps to alleviate pulmonary congestion. And obstructive shock, which is that tension pneumo, pulmonary embolism, tamponade, supine unless a specific intervention like maybe a needle decompression is being performed, and that supports circulation until the obstruction is resolved. And then distributive shock, so septic, anaphylactic, neurogenic, supine, for septic or anaphylactic, supine or semi-Fowler's to aid breathing based on the patient tolerance, and then neurogenic shock, flat with possible leg elevation, but monitor for spinal precautions. And the rationale behind that is that it promotes circulation while supporting airway and breathing. And then in my notes I wrote, however, all caps, follow your local protocols. So within this, we're talking about non-pharmacological intervention. So we're moving down to our second point, which is that prevention of hypothermia. So we want to make sure that we implement measures to prevent hypothermia, such as keeping the patients warm. And then rapid transport, obviously. So we want to make sure we're taking the right patient to the right place at the right time, in the right way, And then fluid therapy. So provide IV fluid therapy as appropriate, manage our airway, and then there may be some medications that need to be administered as well to support our patient care. And we'll talk a little bit about that in a sec. So we've got our IV lines. They're going to be inserted for maybe some immediate replacement of fluid. So, we want to rapidly restore that fluid volume. Potential replacement, so prepare for future fluid needs. And then maybe we need to give some meds as well. So we would have administration of medication. Now the fluid of choice, probably looking at normal saline or LR, once again, depending on what your local protocols say. But all patients in hypovolemic shock, they're going to require IV fluid replacement. So we want to make sure that we're getting some IV access in them. In someone that's likely to develop hypovolemic shock, that's secondary to profuse external bleeding, internal bleeding, vaginal bleeding, fracture of the pelvis or femur, burns, heat exhaustion, intractable vomiting or diarrhea, neurogenic shock, septic shock. So lots of patients that, are going to need these IVs. So IV lines should be inserted to keep a vein open, so maybe a KVO or, however you term it, for potential emergency drug administration. Who might need that? Those patients that might, be subject to a cardiac arrest, so immediate access for those resuscitation meds. So, or maybe those needing parenteral medication, so you need quick access for necessary treatments. And then the IV flow rate should be determined by your protocol to ensure appropriate delivery of fluids and medications. Now, volume expanders. So hypovolemic shock should be treated with volume expanders to replace the fluids lost. So, there's a variety of solutions that have properties similar to those of plasma. Want to maintain the circulatory volume, so help stabilize blood pressure and circulation. And when we're talking about these volume expanders and plasma substitutes, we're saying that they cannot replace red blood cells, platelets, or plasma proteins. They're more readily available than whole blood or plasma. They do not require blood typing. They can be carried in the ambulance for rapid access, and they do not carry the risk of hepatitis or HIV. Now, there's some plasma substitutes, dextran, a high molecular weight glucose polymer, so it stays in vascular space due to its large size, although it has some issues. So it tends to coat red blood cells, which may cause some clotting problems in large quantities, and then it can interfere with cross-matching of blood also. And then plasma protein fractions, so contains albumin and seroglobulin, but it's expensive compared to other options. And you've got, with that, you got I don't know how to say all of these, polygylene, head of starch, other starch solutions. So they resemble osmotic and electrolyte composition of plasma. And the advantage of that is they don't interfere with clotting or blood typing. However, most of us are probably going to look at crystalloids. So crystalloids do not contain proteins or other large molecules. They rapidly equilibrate across the capillary walls. Recommended administration is 2 to 3 times the volume of blood lost, and then the indications are fluids of choice when only salt and water have been lost. So commonly used, normal saline, so widely used crystalloid solution for fluid resuscitation, and then LR. So LR includes small amounts of potassium and calcium. It also contains 28 milliequivalents of lactate, which is added as a buffer. So one of the advantages of this is it's preferred by many trauma surgeons due to the belief it decreases acidosis in patients with severe hemorrhagic hypovolemia. But the crystalloids do not carry oxygen, so they also change the viscosity of the blood by thinning it. So think about that watering down the Kool-Aid. And then they can dissolve clotting factors, potentially impacting hemostasis. So pathophysiology and management of specific types of shock. So on here we see 30 classifications. As we look at these, that may make you think, hey, what about obstructive? And this talk, the way the curriculum presents it is a type of shock. However, it's because of the process that it gets there, I guess, essentially. That probably didn't make any sense, but we'll get there in a second. We'll talk about it. So 3 primary classifications of shock that we're looking at. We see cardiogenic shock, so that results from a weakening pumping action of the heart and then distributive shock. So that's a further broken down into chemical and neural causes. And then dyspeptic shock, caused by fluid shifts associated with massive infections and toxins releasing into vasodilation. We're talking about, so when we get to distributive, you remember we have a couple. And then we have neurogenic shock, caused by blood vessel dilation resulting from brain, spine, or nerve injury. And then hypovolemic results from a significant loss of blood volume. And now that I look at it, I don't see anaphylactic, but we will talk about that in a second, I know. So obstructive shock, here's where I was saying it. So it's talking about because, it leads to obstructive shock. These conditions, these injuries lead to obstructive shock. So conditions that obstruct the flow of oxygen into the bloodstream, they can lead to obstructive shock. So some of those examples might be like a tension pneumo. You remember that's that air trapped in the pleural space and it increases pressure and it collapses the lung. So cardiac tamponade is also another one. So fluid accumulation in the pericardial sac that compresses the heart. Pulmonary embolism, you get that blood clot that blocks the blood flow to the lungs. Airway obstruction prevents oxygen from entering into the lungs. CO poisoning. So there's mechanisms of perfusion reduction. So non-hemorrhagic causes of hypovolemic shock can be grouped based on how they reduce tissue perfusion. So when we talk about weaken the pump, these are conditions that reduce the heart's ability to pump effectively and then increase the size of the container, so causes systemic vasodilation, reducing effective blood volume, and then directly interfering with the circulation. So that's that obstruction, conditions that obstruct blood flow or disrupt normal circulation as well. So initial management for all types of shock, regardless really of what we're talking about, we're going to make sure the airway is clear and secure. We're going to get some O2 to help improve oxygenation. Positioning, we're going to place the patient in a position of comfort to facilitate breathing and circulation. We're going to get our vitals, IVIO access, and then keep them warm. We want to keep them warm to prevent hypothermia. Now let's talk about cardiogenic shock. So this occurs when the heart cannot circulate sufficient blood to maintain adequate peripheral oxygen delivery. So, it really just involves that direct pump failure. So many diseases can lead to destruction or inflammation on the heart muscle. One of the most common causes is going to be an acute MI with 40% dysfunction of the left ventricle, 40% or greater, obviously. There's some other intrinsic causes as well. So right ventricular failure, so that impairs the ability of the right ventricle to pump blood. Valvular disorder, so malfunctions of those heart valves affecting blood flow. Cardiomyopathies, so diseases of the heart muscle leading to dysfunction. You have ventricular septal defects, so an abnormal opening in the septum between the heart's ventricles, and several other things that are small within their myocardial insufficiency, so inadequate blood flow due to the heart muscle weakness. That kind of goes along with that, just the pump not working quite right. So essentially how we see that is we see poor contractility of the heart. So we see a decreased cardiac output. We have an impaired ventricular filling within the heart. There's also some extrinsic causes within that. So, we've got a cardiac tamponade, pericardial tamponade, so accumulation of fluid in the pericardial space, that's compressing the heart. Excessive fluid in the pericardial cavity, so an effusion. Pulmonary emboli, tension pneumo, these are all things that we talked about with obstruction. It's impairing the, decreasing the cardiac output and impairing ventricular filling. So management, need to make sure we put them into a position of comfort. Obviously, prolonged efforts in the field are not recommended. We need to make sure that we're getting them off the scene and to the hospital. Secure the airway, SpO2 levels, supplemental O2, CPAP or BiPAP if that's correct. Obtain a 12-lead crystalloid solution for fluid resuscitation, auscultate lungs, all of those things. If it's clear, then we can start thinking about maybe a fluid challenge. Now, some pharmacological management in cardiac and cardiogenic shock. we can talk about some dopamine administration. So some EMS systems administer dopamine at low doses in the beta range if the patient has a MAP of less than 60. There are some high dose dopamine times where so high dose may be temporarily ordered, but that can compromise other organs as well. So, you need to make sure that you're anticipating that rapid tachycardia. So high doses can lead to increased heart rate, which may further stress the heart. Now, there's definitely some combination drug therapy that goes on, but it's typically within the hospital setting. So, while they're awaiting some further interventions, and while they're waiting for that, it might be a cardiac catheterization or hemodynamic monitoring catheters and insertion of an intra-aortic balloon pump. Those are all things that can go in at the hospital, not things that typically that goes on in an ambulance. And then obstructive shock. So it's characterized by causes that are not directly related to fluid loss, pump failure, or vessel dilation. And the point is that, sorry about that, my chair thing just got wacky. So the point behind that was it's not directly related. It can eventually become that from the obstruction, but typically it's not its own thing is the way the curriculum is lining it out. So it occurs when the blood flow in the heart or great vessels become blocked. And we've talked about those already. So tension pneumo, tamponade, PE, CO poisoning. Tension pneumo caused by the damage to the lung tissue, leading to the accumulation of air in that space. Obviously, this is a life-threatening condition, due to the kinking of the vena cava, which occurs as the mediastinum shifts. So that shift can severely compromise venous return to the heart, which leads to decreased cardiac output. So really the only thing that we can do to help prevent death in this situation is that decompression of the injured side of the chest. And when we talk about that decompression, that allows air to escape and restores normal pressure in the pleural space. And then a tamponade, not something we're able to really do a lot about other than recognition. That's going to be our best tool. So that tamponade can result from blunt or penetrating trauma, tumors, or pericarditis, which is that inflammation of the pericardium. It can progress quickly and leading to severe complications. So it occurs when blood leaks into the pericardium, causing that accumulation of blood. With that accumulation of blood, we start to see compression of the heart, and then with that compression, then we start to see obstruction of blood flow. So, that continued pressure just obstructs the blood flow into the heart, and once again, that starts to impair the cardiac output. So some signs, one of the big ones is going to be muffled heart sounds. So you start to see those diminished, or you hear, start to hear those diminished heart sounds due to fluid accumulation. So you also see a narrowing pulse pressure. So your systolic and your diastolic really start merging together. So you get a narrowing pulse pressure. That indicates that, we've got some compromised hemodynamics. Electrical alternans, so this will make more sense when we get into EKG, but you see a variation in the amplitude of QRS complexes on the ECG, often accompanied by a small QRS. So what we're saying is you might see a normal QRS and then it's followed by a little bitty dinky QRS. So it's identical complex, but then it goes back to a normal sized one, and it can go in patterns and without patterns, but that's what electrical alternans is. So just recognize now that that's something that you can see with cardiac tamponade. So what do they do for that? So they do a pericardiocentesis. So that's that procedure to remove that fluid from the pericardial sac, relieving pressure on the heart, and the best thing is it restores that heart back to normal function. Then we get into distributive shock. So distributive shock occurs when there's this widespread dilation of the resistance vessels, the capacitance vessels, or both. So there's some physiological effects. So we see some pooling of blood. So that circulating blood volume pools in vascular beds, reducing effective circulation. We see some decreased tissue perfusion. So that pooling leads to inadequate perfusion of the tissues and organs. Now the different kinds of distributive shock is we see septic shock. That's that caused by that severe infection that leads to a systemic inflammatory response. And then neurogenic, resulting from spinal cord injuries or damage to the nervous system, causing a loss of vascular tone, and then anaphylactic, a severe allergic reaction leading to widespread vasodilation, and then psychogenic shock, which is triggered by emotional distress, leading to temporary loss of vascular tone and blood pooling. So within distributive shock, let's start with septic shock. So that's defined by the presence of sepsis syndrome and a systolic blood pressure of less than 90. So a decrease from that baseline blood pressure of more than 40 millimeters of mercury. So you get this subset of sepsis associated with circulatory, cellular, metabolic abnormalities, leading to a higher risk of mortality compared to sepsis alone. So some critical criteria is hypotension requiring vasopressors to maintain a MAP of at least 65, and then a serum lactate greater than 2 millimoles per liter, persisting despite adequate fluid resuscitation. So there's lots and lots of reasons for this, commonly caused by gram-negative bacteria, but it can be from gram-positive, but it's commonly from a gram-negative. Fungi, viruses, lots of things when someone gets sepsis, essentially infections. So inflammatory response, so that infection activates an inflammatory immune response, and that results in increased microvascular permeability, vasodilation. Then we start to see that third space fluid shift, and then some microthrombi formation. So there are consequences. An uncontrolled and unregulated response leads to hypoperfusion to the cells. I'm talking about distributive shock. And within that, the septic shock is, I guess. So insufficient fluid volume with these septic shock patients. So there is an insufficient volume of fluid in the vascular system, remember that's that container. So we start to see some fluid leakage out of the vascular space and collects in the respiratory system, contributing to complications such as pulmonary edema. Now, the larger than normal vascular bed must accommodate a smaller than normal volume of intravascular fluid, which leads to some inadequate perfusion of organs and tissues. It's kind of just some presentation. We're still talking about septic shock. So it presents similarly to hemorrhagic shock, characterized by the cardiovascular compromise, but there's some key difference. So the key difference typically was going to be exhibit warm or hot skin due to elevated core temp, distinguish it from hemorrhagic shock. And we'll talk a little more about that, but we can also see when it's cold, when that whole system has kind of quit fighting and has given up, and you get into a cold shock that we treat it a little bit differently. But the way that we treat these, treatment requires complex hospital management. Obviously, our transport protocol is going to get them to the right place, obviously, again, at the right time. O2, ventilatory support if needed. So hypotensive patients, so we want to administer dopamine to maintain blood pressure and renal perfusion. Now, warm shock management, so if the patient remains in warm shock, you give norepi to help stabilize the blood pressure, and then we have a cold shock management. So patients in cold shock, it will administer epi to improve circulation and support vital organ function. And then you can use blankets to conserve the body heat and prevent hypothermia. So obviously some crystalloids to maintain a palpable radial pulse, ensuring adequate circulation. So, we want to make sure that they're adequately hydrated before we start using vasopressors if possible. Neurogenic shock, so that's spinal shock is a local neurological condition that occurs after a spinal injury, resulting in motor and sensory losses. So this happens, causes primarily result from spinal cord injury, also can derive from other medical causes. So the loss of normal sympathetic nervous system tone leads to some vasodilation, and then the muscle and the walls of the blood vessels are deprived of nerve impulses, preventing that contraction. So all vessels below the level of the spinal injury dilate widely, so they just get blown out, and this dilation causes relative hypovolemia, resulting in hypotension. So relative bradycardia occurs due to disrupted autonomic regulation. So the skin, it appears, baseline color, warm and dry due to cutaneous vasodilation. Epinephrine and norepinephrine are not released, impacting the cardiovascular response because of that injury, and the patient will not sweat below the level of the spinal injury. So the pathophys here, continuing that damage to the spinal cord, may also affect the autonervous system. So swelling and edema of the spinal cord begin within 30 minutes after the injury, and then there can be a secondary cord injury which develops over the first few days following that initial insult. Now, severe pain may be present just above the level of injury, and then they can be characterized by flaccid paralysis, so that loss of muscle tone and strength, flaccid sphincters, so loss of control over the sphincter muscles, absent reflexes, loss of reflexes below the level of the injury. So really the level of injury to the spinal cord is related to the severity of the neurogenic shock development. So injury above T1 can disrupt all spinal tracts, controlling the entire sympathetic system. Injuries from T1 to L3 may partially interrupt sympathetic outflow. The higher the spinal injury, the more likely spinal shock will develop. So kind of just some management things. So the care for spinal shock, it's similar to the general management of any patient with shock. So, immobilization, because we're talking about an injury. So ensure the patient's immobilized to prevent further injury. Make sure we're keeping them warm, because those spinal injuries can disrupt those thermoregulatory mechanisms. And then we need to determine the necessity for IV fluids based on their hemodynamic status. Want to make sure we're maintaining them at 90 millimeters of mercury or higher. So volume loading with normal saline. So we might, you might see administer boluses of 20 mils per kilo, increments up to 2 liters via large bore IV, and then use warm fluid in the event you have it to prevent hypothermia. Now, pharmacological interventions, so in cases of pure neurogenic shock, using vagal blockers and vasopressors can improve hemodynamic status, so as they may be more effective than overhydration. And then we consider the use of steroids per local protocols to manage inflammation and support recovery. So anaphylactic, mentioned anaphylactic. It's a severe reaction to a substance which a person has been sensitized. So when we say sensitized, that sensitization refers to the process of developing a heightened reaction to a substance. And then subsequent exposure after sensitization results in a more severe reactions. So that within this, there's no loss of blood and no vascular damage, with only a slight possibility of direct cardiac muscular injury. But they do experience widespread vascular dilation. So that vascular container becomes larger while the blood volume remains less, leading to inadequate perfusion. So when exposed to an allergen, then the immune system releases chemicals, primarily the histamine, which causes multi-system involvement, and then this reaction causes severe bronchoconstriction. It can lead to urticaria, so hives. That immune response results in a widespread vasodilation, leading to distributive shock, a type of shock caused by the improper distribution of blood flow. And then we see fluid leakage. So fluid leaks out of the blood vessels into the interstitial space, results in hypovolemia, a decrease in circulating blood volume, and then some significant swelling, accumulation of fluid in those surrounding tissues. So some management things. So it needs to occur pretty quickly when we're talking about anaphylaxis. So if possible, we want to eliminate that exposure to the allergen. So in the event you're able to remove kind of that inciting thing, that inciting cause, that would be good. Address life threats, so ABCs. Evaluate their ventilatory status, so maybe they need to be bagged. And then considerations, obviously epi. You want to reverse the target organ effects of anaphylaxis. You also want to provide cardiovascular support, so IV fluids with crystalloid solutions to support circulation. Consider a bronchodilator, so we're talking about bronchoconstriction here, so to alleviate that bronchoconstriction, if they have it. and then using an antihistamine to impede further mediator release. And then obviously transport, transport considerations. So take their epi injector to the hospital for further treatment in the event that they use their own, and be prepared as well for another dose if you have a long transport. So psychogenic shock. It's sudden reaction of the nervous system that causes temporary generalized vascular dilation, leading to syncope or fainting. So what happens, we see that blood pools in the dilated vessels, resulting decreased blood flow to the brain. So the brain ceases to function normally due to the insufficient perfusion, and that causes them to faint. So, there could be some life-threatening causes. So potential serious underlying causes of psychogenic shock can be due to an irregular heartbeat, or even maybe a brain aneurysm. So a rupture can lead to that loss of consciousness and other critical symptoms. So there's some other causes as well. So receipt of bad news, so that emotional distress can lead to syncope. Fear of unpleasant signs, so anxiety-inducing situation may provoke a reaction. Just recovery, talking about recovery, circulation of the brain is typically restored, allowing for the return to normal brain functioning. So, assessment after they faint, so if they fall, and it's important to check for injuries, conduct your thorough assessment. And then if they cannot walk without experiencing weakness or dizziness or pain, then you might want to suspect another underlying problem. Obviously, you want to record your initial observations, looking for vital signs and LOC, or their level of consciousness. Obtain an ECG, make sure we don't have some kind of weird and funky rhythm going on. Get your information, learn from your bystanders, so whether they complained of anything prior to fainting or how long maybe they were unresponsive. And we move on to hypovolemic shock. So hypovolemic shock is due to inadequate blood volume. So it can be classified into hemorrhagic and non-hemorrhagic shock. So hemorrhagic shock, that blood loss can be internal or external, and then non-hemorrhagic shock, you can lose, plasma loss can occur due to burns or other conditions. There can be electrolyte solution loss, so that's caused by vomiting, diarrhea, excessive sweating. Obviously, non-hemorrhagic hypovolemic shock occurs when the fluid loss is contained within the body. So there's lots of things there, excessive sweating, peritonitis, pancreatitis, those things can also cause that as well. And then a whole host of medical conditions, so diabetes, acute renal failure, osmotic diuresis. So some common signs and symptoms, so loss of appetite, so reduced desire to eat. We're talking about symptoms of dehydration, nausea, vomiting, fainting when standing up. So if they get some lightheadedness or a loss of consciousness upon standing. When we talk about the signs of dehydration, poor skin turgor, hopefully you remember that, but that skin loses elasticity, does not return to normal quickly when pinched. So, think when we pull up on there, if everything goes back normal, then we probably have good skin turgor. However, if it's delayed, then we may have poor skin turgor. So shrunken or furrowed tongue, that indicates fluid loss and dehydration. Sunken eyes, obviously a weak and rapid pulse. So if it's weak and increases more than 15 beats a minute when the patient is raised from a recumbent to a standing position, that's also a sign as well. So management of dehydration. Administer an IV of normal saline or LR solution to rehydrate the patient. Put them in a position to optimize circulation to the brain in accordance, obviously, with your local protocols. Want to make sure we're doing airway management, IV line establishment, getting that IV, and then administering some saline or LR. So consider administering 20 mils per kilo in 250 mil boluses. Obviously checking blood pressure, obviously checking lung sounds with these. Don't administer anything orally to the patient to avoid further risk of vomiting or aspiration. If they do vomit, might think about administering an antiemetic to manage nausea and prevent further vomiting. And then still talking about hypovolemic, so monitoring during our treatment. So we want to continuously monitor, following parameters. So ECG rhythm, we want to make sure their level of consciousness and responsiveness is good or is the same or better. Their pulse rate, their blood pressure, SpO2, their end tidal, pulse assessment. And then depending upon what's going on with them, there are some things that your medical control may order depending upon your patient status and how they're responding to treatments. You can see things like sodium bicarb being given to treat acidosis, or even a vasopressor to enhance vasoconstriction. That also improves blood pressure. So the one thing we want to make sure that we do is don't wait for the blood pressure to fall before suspecting shock and then initiating treatment, and that's going to be for all shocks. The goals of this shock treatment, the main objective in treating shock is to protect and save the brain, lungs, and kidneys. So there's some indicators of organ perfusion. So within the brain, it's best indicated by their state of consciousness. And then kidney, so much we're not going to really know, but that's gauged by urine output, or hopefully we're not going to know. Adequately perfused kidneys produce at least 30 mils to 50 mils per hour. Peripheral perfusion, so estimated using cap refill, however, not really the most reliable indicator. But we want to rely on the patient's state of consciousness to evaluate how well vital organs are being perfused. And we move on to respiratory insufficiency. So what is that? We're referring to the inability to breathe in adequate amounts of oxygen, affecting the ventilation process of respiration. So insufficient oxygen in the blood can lead to the development of shock due to inadequate tissue perfusion. So, certain poisons can impair the ability of cells to metabolize or carry oxygen. Obviously, carbon monoxide, it binds to hemoglobin, which prevents O2 from binding, and that results in a hypoxic state where tissues are deprived of oxygen. And within cyanide poisoning, that cyanide interferes with cellular metabolism, impairing the ability of cells to utilize oxygen. So this can lead to cellular asphyxia, where cells are unable to perform essential metabolic functions. Now, anemia, we're still talking about this respiratory efficiency, or insufficiency rather. Anemia can be something that can certainly directly affect this. It's characterized by an abnormally low number of red blood cells in the body. So maybe that's because they, had a loss of blood. That would decrease in the red blood cell count. Deficiency in vitamins and minerals, the lack of essential nutrients such as iron, vitamin B12, all of those things can impair red blood cell production. Maybe they even have some underlying disease processes. However, there can be an impact on tissue oxygenation because of these decreased red blood cells. So tissues can become hypoxic, so we're saying they're deprived of adequate oxygen. So even if a pulse ox indicates adequate oxygen saturation, tissue hypoxia can still occur. So this phenomenon is referred to as hypoxemic hypoxia. So if you think about it, there's just not all that many red blood cells. However, the few that are left in there are completely saturated. Your pulse ox is going to read a high reading because every one of the red blood cells it's reading are all saturated. So it's going to read 98, 99%. However, the problem is not the O2 being loaded on there. The problem is there's not enough red blood cells for enough O2 to get on. So that goes into that hypoxemia. Now, treatment for shock due to poor respiration. So some immediate actions, obviously seal a hole in the chest. So, if there's penetrating chest wound, we want to seal that, preventing air from entering the pleural space. Want to stabilize impaled objects, make sure that we're securing and maintaining the airway, clearing obstructions from the throat. Want to make sure that we're monitoring everything, make sure we're making good decisions on who goes where and how fast they go there, how they get there. Then transportation. So preparing to transport a shocky patient. So when preparing to transport a patient in shock, we want to consider some following questions. So we see them listed here: when, where, and how. Assess the urgency and timing of the transport based on their condition. We want to determine the most appropriate medical facility and then decide on the mode of transportation. Maybe that's ground, priority status to wherever it is that your level 1 transport, what level 1 hospital is, trauma facility, or maybe it's by aeromedical, so maybe it's by air. We want to make sure that we're limiting scene time. Earlier we've talked about 10-minute scene time. The last video we talked about the whole thing, that golden hour, taking 1 hour from the time the accident happened till the time they're in the ER would be better than the time they're in surgery. But that golden hour. And then know your access protocols. So be talking about aeromedical transportation. So be familiar with those procedures for accessing aeromedical transportation. Obviously including the criteria for its use and then the logistics involved. So consider the priority of the patient based on their condition and the urgency of their needs, and evaluate the ability of a regional trauma center to ensure the patient receives the appropriate level of care. And what we're saying is, don't take the right person to the wrong place. So you've got someone pretty banged up and they're a priority 1 patient, need to be at a level trauma, and you just head out to, a local doc in the box type place, and that's not going to be so pretty good for someone who's desperately needing, advanced care. So in shock, when we're talking about these patients, they definitely would benefit from early surgical interventions to address these underlying issues. So make sure that we're transporting is directed to a facility with the appropriate capabilities for managing trauma and shock. And if it's not available, then might consult your medical director. Maybe they might be able to help you make a better decision. This may involve just transporting to your local facility for initial care, and then once that initial care is taken care of, then we can arrange transport to the city or wherever it is that they get going to. That's it. That is the end of part 2. So we'll see you guys soon.